All right, AI is writing scripts now. 15,000 nurses are on strike in New York. United is actually kicking people out of nursing homes or keeping them there. The vaccines have changed, and also the food pyramid is updated. That's all coming up on the Dr. Masterson Show. So AI is writing prescriptions now. So under Utah's regulatory sandbox law, a tech company called Doctronic, appropriately named, has been authorized to use AI to autonomously prescribe refills for 191 chronic medications like statins and birth control without a human doctor reviewing the order. The service charges only $4 if AI approves you, but significantly more if the AI flags a risk and refers you to a human. Unfortunately, this might create some perverse incentives. The Salt Lake Tribune was commented saying, Utah has launched a first-of-its-kind trial that lets artificial intelligence system approve prescription renewals without a physician signing off. The company currently charges patients $4 per renewal in Utah, which covers the cost of identity verification and retrieving medical records. Patients whose requests are not cleared by the AI can be routed to a free video visit with a physician charge of $39. Okay, so let's just break that down for a second. First thing that pops out to me is legitimately the economics of the entire situation. Primary care, one of the most important specialties in the healthcare space, survives on chronic care visits. These are the doctors that go to medical school and are salt of the earth. They're taking care of the chronic pain medications, the chronic blood pressure, statins, and the nuances that come with those. If we take those patients out of the PCP's clinic and just give them an exceedingly complicated patient, it's going to increase burnout. It's going to make surviving in primary care more difficult, and we already have a doctor shortage. If we take away the thing that keeps clinic moving or the thing that makes clinic a little bit more manageable, it's going to remove people from the primary care space. You're going to diminish people becoming PCPs, and you're going to increase the competition for specialties. Now, specifically, one of the things that really concerns me is the incentivization this puts on a patient. Let me give you an example. Somebody comes into my office and says, hey, doc, I need to refill my medication. And they know that if I say to them, is there any problem with your medication? Are you having any symptoms or side effects? If they say yes, I'm going to charge them $40. If they say no, it's $4. What are most people going to say? No, I'm doing fine. The AI is going to miss. Patients, I know that a lot of tech companies don't know this, patients are intelligent. They can tell how to work the system. And they're going to try to save money. And a physician or a practitioner that's sitting in the gap of that can say, hey, it looks to me like your blood pressure readings haven't been where they need to be. Or it looks to me like you're a little flushed. Or is something changing in your vision? Maybe we don't need to do the same medication. You take a human out of that, a human that's in it can optimize it to save money, which isn't appropriate, right? That's going to create perverse incentives. And if I'm sitting between, and we've already seen this, people having to choose between paying for rent or paying for healthcare. So if I have to choose $4 to get my life-saving medication refilled, or gosh, $40 if I have a question, a lot of people are going to be picking that $4 option. And I think even deeper than this is the art of medicine. And John Maxwell has this really famous quote that no one cares what you know unless they know that you care, right? How many people do you think will feel though AI cares? Now, I know a lot of people are just like, hey man, I just need to refill. What we've learned in our practice is that there's a lot of patients that don't want to take a medication, aren't compliant with their medication until I come behind them or one of the other providers comes behind them or practitioners and says, hey, here's why you need to take this medication. If you don't, it's going to lead to worse outcomes. That physical exam, that is the art of medicine. That's important in patient care. And if we remove that, we open this big opportunity for this very unique amount of liability. And let's just talk about liability for a second. I mean, who's on the hook for this? Because if we're going to say the AI is responsible for the decisions that it makes, but then it's not liable if it refills the wrong medication or prescribes the wrong medication because it spells the medication wrong, or it is liable, and then we tell you that the AI that works for one of the payers is not liable if it denies care? Let's think about that for a second. I'm an AI, and my primary directive is to approve medication refills. That's my primary directive. I make a mistake. Am I liable for that? I'm an AI that's primary directive is to deny or approve healthcare, a surgery, a radiogram, whatever. I'm definitely not liable per the current system. If we're going to assign liability equally, that means that the new AI that's writing scripts can make mistakes all at once, and whoever's running it, in case this tech company, is not liable. How do we feel about that? What's that going to lead to? Because I can tell you what it's going to lead to from the payer side. It's going to lead to promoting profitability. Because if there's no liability, you're just going to get more profitability. So it's something we need to stop and think about before we continue to push further on. All right, the NYC nurses are on strike. Over 15,000 nurses at New York's wealthiest hospitals, Mount Sinai and New York Presbyterian and others, have walked off the job in a historic strike that has shut down non-emergency wings across the city. While safe staffing ratios are a core demand, the flashpoint has come because hospitals have attempted to cut the health insurance benefits of nurses themselves. The union describes this as moral bankruptcy, that the people saving lives in the ICU cannot afford to see a doctor, while management claims rising insurance premiums have made the old plans unsustainable. According to the Washington Post, Tuesday is the second day of the largest nurse strike in New York City's history. Management at the richest hospitals in New York City are threatening to discontinue or drastically cut nurses' health benefits. It is deeply offensive that they would rather use their billions to fight against their own nurses than settle a fair contract. Negotiators say that the sticking point is the rising cost of premiums and that payers are passing this on to the hospital systems. Are we surprised? I mean, I'm trying to ask that question honestly, but not. I mean, you have two primary issues here, right? You have the payer and you have the corporate healthcare system. And the primary motivation of those companies, and I hope this doesn't shock anybody. This is not shocking. The primary directive of a CEO of a healthcare company, a hospital, insurance, is to make the shareholders money. Like, that's their primary directive. Just like a physician or a practitioner, their primary directive is to take care of patients. So you have to understand, if that motive is present, look at what costs go to. So we can't really be surprised if the margins or if the payers raise rates, that the hospital corporation is going to act differently. The payer's going to say, hey, you know what? Our margins are going to shrink if we don't raise the premiums because we lost the subsidies. Okay, the CEO of the hospital system is not going to work any differently. They're going to be like, well, if our margin goes down, we're going to have to cut what we offer the nurses, right? We've already seen them expect the nurses to cover more, right? And that's what the staff ratios are about. So for those who don't know, there is the specific directive, depending on where you are in the hospital, of how many patients that you should be taking care of. In most ICUs, it's 2 to 3 at max per nurse. In most step-down units, once you leave the ICU, it's a little bit more than that. And in the general floor, it shouldn't be more than 6 to 10. Now, some people are literally taking care of 11, 12, 13 patients. And I think, speaking as someone who's been in residency, this is the similar heart, right? It's, hey, healthcare worker, just deal with it, right? The patient needs you. Yeah, I know you're not on call, but if you could just take care of the patient. Yeah, I know you're only supposed to see 10 patients, but if you could just see 12. Yeah, I know that you're not supposed to cover that, but the patient needs you. That only works when there's balance. That only works when the person making those decisions is also on the hook, right? And what we've learned over the last several years is that the corporate system is taking advantage of the providers and practitioners and expecting them, nurses in this case, just do it. And good for the nurses for saying, no, I'm not doing it anymore. Like, the system that you've built, these expected margins from your shareholders, you may not be able to deliver this year because you have to pay for a nurse. For example, in our clinic, outpatient ear, nose, and throat, there are some roles here I would love to hire a nurse, but I can't. Because you know why? I can't afford a nurse. A nurse is a certain level of quality and intervention. And if I can't afford that level of quality intervention, I don't hire a nurse. In the hospital, that's the same thing. If I've got so many patients on a floor, that is a specific number of nurses I've got to hire to support that number. If I can't afford that, I've got to change what I'm doing. All right, United Healthcare and the eviction algorithm. So a class action lawsuit is exposing how United Health used an AI algorithm called NH Predict to set a rigid eviction date, and I'm using that word sparingly, for elderly patients in nursing homes, often cutting off the coverage weeks before doctors recommended. But the scandal goes even deeper. New reports now reveal that the insurer paid bonuses to nursing homes that prevented patients from being transferred to hospital systems, effectively incentivizing them to keep sick people in facilities that they couldn't handle. The result was frail patients being forced to stay in underequipped facilities or to be sent home too early. According to The Guardian, the lawsuit alleges that United Healthcare routinely denied claims by using artificial intelligence program and paid bonuses to nursing homes to keep residents out of hospitals, even in the cases where hospitalization was medically necessary to save money. Defendants continue to systemically deny claims using that they are a flawed AI model because they know that only a tiny minority of policyholders will actually appeal. So here's what you need to understand. The primary part of the suit is a breach of contract. In the contract, it says that patients will be given a doctor to determine medical necessity. So going back to the AI ideology, if we're allowing doctors to become the parishioners over the decision-making of keeping a patient in the hospital or sending them home versus transferring a patient to a hospital and nursing facility versus we put AI in that driver's seat, AI's directive is to follow protocol for the primary output of the organization. And again, let's call it what it is. Any payer, not just United, any payer, their primary directive is increasing shareholder value. So if the AI is built for that, what is going to be the primary endpoint? Very similar to this, it's going to deny most of the claims. It's going to optimize workflow. And as a doctor, I cannot tell you the amount of times I've been on the phone with a peer-to-peer when I'm on the other line, the person says, oops, it looks like they just read that wrong. Or oops, I guess we didn't see that in your HPI. What do you mean you didn't see that in the note? Like it's been there the whole time. It was seen. What the problem is that they're hoping that you don't call it out. If they can create administrative burden, the likelihood of a denial being addressed is less than 70%. And 90%, according to the news report, were appealable. 90%. 90% were wrong. If they deny 90% of claims and only 30% are over or even appealed, think about the profit margin there. And truly, one of the darkest parts of this is that not only are we transferring patients not soon enough, but we're letting patients go. Now, just so everyone understands how transfer to hospitals work in nursing facilities, I see this again and again in all sections of healthcare. There's something called INTERACT, right? It's interventions to reduce acute care transfers. What does that mean? If you're in healthcare, you understand this, but there's a lot of times that nursing facilities are all over the place, and their primary protocol is to just take care of the easiest patients. And if there's a cough, a sniffle, or a sore throat, send them to the ER. That's not an appropriate use of care. And so you have appropriate evidence-based guidelines in this INTERACT, interventions to reduce acute care transfers, that's rolled out by some university. And its purpose is to save the healthcare system money. And I'm talking about the healthcare system writ large, Medicare and Medicaid. But payers will utilize protocols like this to proactively create more profit, unfortunately. And so what you have is any time, again, that the balance is not appropriate, you get an inappropriate use of healthcare workers and healthcare dollars. And if we don't, again, call it what it is and try to put more, not authority, but more liability on the right person, in this case, the payer, we're not going to see a shift. So even going back to earlier what we were talking about, are we going to have the AI that's writing prescriptions be liable, but the AI that's writing denials not be liable? We need equal liability. Anybody, a payer, an AI, a physician, a practitioner who's making healthcare decisions, refilling a medication, deciding if they're going to transfer to a hospital, anything. If you're making patient care decisions, you are liable for those decisions. And if we don't do that, we're going to continue to get the same outcomes that we have now. All right, I'm sure everyone has heard the vaccine schedule has changed in January of 26. A major policy shift intended to align with European standards. The CDC and HHS have reduced the universal childhood vaccine schedule from 17 down to 11. Vaccines like hepatitis and meningococcal have been moved from mandatory to shared clinical decision-making, which is optional, leaving it up to parents and doctors to decide. The administration argues this respects parental rights and mirrors countries like Denmark, but pediatricians warn it will lead to outbreaks of preventable diseases, in schools and daycares. According to KFF, on January 5th, the CDC reduced the number of vaccine it recommends for children from 17 to 11, moving shots like hepatitis B to shared clinical decision-making. Federal health officials said that the update is intended to align the U.S. with peer nations. Experts warn that moving vaccines out of the universal category may lead to insurance companies stop covering them. So let's talk about the payer gap. Let's be honest. How many times have we seen the insurance companies do the right thing? And if we change anything in healthcare from a recommendation to an option, what do the payers do? Now, the good news is that all the state-funded programs are requiring that all vaccines are still covered. And that's great, that's appropriate, that's evidence-based. But the more that payers have the opportunity to stop covering interventions, they likely will. Now, is there any evidence to support this right now? Absolutely not. But if we look at, in totality, anything that has been recommended against from a therapeutic standpoint, medications, drugs, vaccines, the likelihood of payers continuing to do those things is very low. And so don't be surprised if in the future, you're coming to the physician to get a vaccine that's no longer on the CDC guidelines, and it's not available or not covered because these recommendations have changed. The other big piece of this is really within the school boards. A lot of school boards require vaccinations in order to make sure students can be enrolled. Now, there are exemptions for this, but what type of vaccine schedule do we adhere to? Is it the CDC or the American Academy of Pediatrics? Every school in America now has to decide which program it's going to follow. And if you transfer, does it still apply? All questions still yet to be answered with the change. This is here to be yet determined. And finally today, there is a new food pyramid. On January 7th, the USDA and HHS released a new 25 to 30 dietary guideline, which represent a historic reset in the U.S. nutrition policy featuring a new pyramid. According to The Guardian, the new guidelines deliver a clear message to eat real food, but critics say the recommendations are inconsistent with confusing tables that seem to promote high-fat foods while still warning against saturated fat. The visual prominence of things such as butter might have you think that saturated fats limits are tossed out, but actual guidelines retain the long-standing upper limit. So here's the most important takeaway, is that it's a non-shift shift. The big claim is that there's a revolution, but it's mostly confusing. We've cut back on processed. Isn't there something else to focus on? The answer is no. What is most concerning is that we've put so much effort into the change, but the change is just a reemphasis of the previous guidelines. There is some confusion around the actual table itself, like the prominence of butter and the high use of animal-style proteins, but at the end of the day, the primary guidelines haven't shifted much. We are being intentional now, and I will give credit for that. We are being intentional in saying, let's cut out processed food. Let's not have as high emphasis on sugar. But now the fact that we're pushing animal proteins only does raise some flags for concern, according to dietitians. Well, that's it for us here at the Dr. Masterson Show. Be sure to like, subscribe, and share this. Leave us a review. It really helps us promote the ideas that we're trying to spread, and that is really just actuality. We want you, healthcare workers and the like, to know what's actually going on within the healthcare space. Thanks so much for hanging out.